you very much indeed. Good morning, everyone. Thank you very much to the organisers for the invitation to come and talk to you about something that I hope will be a bit of good news. And thank you, Kira, for a brilliant talk. I'm familiar with the DAR's work, and it might even get a small mention in this document, which is forthcoming. So what I'm here to talk about in my role for NHS England, but I do work as a clinician and a clinical academic at UCL and UCLH, is the work that we're doing on sepsis and the broader context of what we're doing on quality in the NHS for the next few years. So, first of all, you will all be familiar with the 10-year health plan. I guarantee that no one in this room will have read the whole document. Probably. Some of you might have read the executive summary. You're going to be really pleased to hear that I'm going to give you an even more executive summary right now. So, thinking back, September 2024, so just after the new government came in, Lord Darzi was commissioned to do an evaluation of the state of the NHS, and it was a pretty gloomy picture that he painted. And amongst the messages that he talked about were the fact that we'd become too focused on this thing and not on that thing, and the need to refocus ourselves on quality amongst many other things. Tied in with that then, became the publication of the 10-year health plan for England, which came out in July 2025 and sets out a really bold and ambitious view of the future with the three strategic shifts that we're now all very familiar with, I'm sure. So the analog to digital, the secondary care to neighbourhood, and the sickness to prevention strategic shifts. And I doubt that any of us would disagree that those are things that we've got to do. But it's the how, isn't it? And the 10-year plan was very, very big on ambition and strategy, but not necessarily so much on implementation. And so obviously all the work on implementation and designing how we're going to get to those ambitions is what's followed from there. So we have now various things like a cancer plan already published. We've got the NHS 10-year workforce plan due to be published imminently. And then there's going to be a slew of other documents and so on coming out, of which the modern service frameworks are one. Now, the government said they weren't going to reorganise the NHS, but here we are. And NHS England is being folded into the Department of Health and Social Care, a project that is likely to come to an end within this financial year or thereabouts. It's requiring legislative changes as well. This is the new operating model. Now, to those of us that are in the room that are coal-faced clinicians, you're kind of like, well, I mean, what difference is this going to make to me on my day-to-day work? But I suppose the one thing that I would say is it is about this continued emphasis on moving the decision-making as close to the patient as possible and removing as much as possible from the centre. And the reason that that's important is because there's both clear benefits associated with that, but a few risks as well. So the benefits clearly are that if systems, so ICBs, and regions, particularly regions are being really strengthened, are given more authority, then the idea is that they deliver services that are fit for the patient population that they look after. And it's very, very clear that the patients that are looked after in a more deprived part of Birmingham, for example, are very, very different to the patients that are looked after in a leafy part of Surrey. And so it is important that we direct services according to local needs. However, there are some safeguards that need to be put around that, because surely there has to be some basic standards that mean that there is equitable access to care for all patients, no matter where they live. And so the flip side of the devolving as much as possible to the local level is the headlines about postcode lotteries. Those are the two sides of the same coin. And so we do need to manage that while continuing to devolve as much as we can down to as close to the patient as possible. Now, I'm going to focus in on quality here. So some of you in the room will remember Darzi's High Quality Care for All publication that came out, I don't know, maybe 15, 20 years ago. And coming out again of Darzi's report this time round is this new approach to quality. And here are some of the early deliverables on that. The National Quality Board thing, again, won't really mean much to those of us that are clinical coalface, but the quality strategy will, because it's going to direct how we approach quality in our day-to-day working, how we measure it, how we improve it, and all of those sorts of things. The modern service frameworks I'll come to in a moment. Care delivery standards in the middle there. So that's a revision of the old 7-day service standards that Bruce Keogh brought in 10 years ago. I'm leading that piece of work as well. And it's about making sure that what we give to patients, particularly in urgent and emergency care pathways, they can expect the same standards, the same opportunities, the same care 7 days a week, which again is not something that I think any of us could possibly disagree with. The maternity outcome signal system is an exciting development that those of you that work in obstetrics will probably be aware of already, but essentially this is a live surveillance system which will flag where we start to see outliers, statistical outliers, in key outcomes like neonatal and maternal deaths. And the important thing is it's about picking up signals as early as possible, not waiting for a national audit to come around on its reporting cycle once a year, once every 18 months, not waiting for someone to blow a whistle. It's about using the data as best as we can to give near real-time reporting and feedback. And then a whole bunch of different other reporting requirements and quality requirements that are coming through. But I'm going to focus now on the modern service frameworks. These are essentially 10-year plans for particular conditions. So those of you that have read even the exec summary will know that there was a commitment to develop 3 modern service frameworks in there, one on frailty and dementia, one on end-of-life care, and one on cardiovascular disease. But the sepsis modern service framework, which I've co-led with Dame Sue Hill, who is the Chief Scientific Officer at NHS England, was commissioned at the same time. So although it wasn't in the 10-year plan, we've been working on it since August, September of last year. So why now? Well, sepsis, we're all here to discuss it, so this is a sort of preach to the converted bit of my talk. But you all know that the definition of sepsis from an academic perspective is infection with a dysregulated host response and some organ dysfunction. We all know again that infection is common, but sepsis is much less common, but obviously potentially deadly, and that's why we're all sitting in the room. Now, one of the things that I've found really challenging about leading this piece of work is the lack of clarity that we have on the data, and it's interesting just having heard a brilliant talk about how we can use data effectively. Actually, the epidemiological data on sepsis I find really confusing. So, for example, some of you might have read Chris Whitty's report at the end of last year. The Chief Medical Officer publishes a report every year, and last year's report was on infection. And if you look at that report, it's got this graph at the bottom in it. And what this graph shows is the absolute numbers of deaths due to infection by age group. So at the bottom is the 0 to 4 year age group, and at the top is the 95 and overs. And so it goes up in 5-year intervals all the way up to the top. So a few things here. So unsurprisingly, deaths from sepsis, there's a small peak at the bottom in neonates, and then basically deaths from sepsis, absolute numbers go up as you get older, again unsurprising, and then tails off in the very, very old, because obviously there are fewer very, very old people around. But what I want to draw your attention to is the colours. Okay, so the colours show you the causes of infection. Okay, so this is according to death certification data. So there are different colours for UTIs, respiratory, cardiovascular, and so on. Now, what I find really interesting here is that the orange bars are septicemia, so what we would call sepsis now. Okay, so you tell me how you die of an infection without having sepsis. Okay, so yes, it's true, and I was challenged by my friend, the National Clinical Director for Stroke, because he said, of course you can die from an infection without having sepsis. You can develop infective endocarditis, and you can throw off a blood clot, and that can give you a stroke. And all right, the exception that proves the rule, yeah? But basically, if you get an infection, you die from sepsis, in my view. Now, that doesn't mean that the death is inappropriate, okay? So what we don't want to do is throw the kitchen sink of highly invasive interventions at the very elderly, in whom getting an infection can be a humane way to die in someone that is towards the end of their life anyway. And it's not just the elderly, it's the frail of any age. It's people who have multiple long-term conditions that means that they're towards the end of their life. We know that over-intervention in people like that is the wrong approach, and actually making sure that we design the right care for those people through advanced care planning, treatment escalation planning, whatever it is, good health care, health and social care, is the right approach. But the point here is that the numbers are not helpful. And so if you had to ask me how many people die from sepsis every year, what I can do is I can point at death certificate data that have as a 1A on the death certificate sepsis, and that's about 23,000 deaths, and have somewhere on the death certificate sepsis, and that's about another 23,000 deaths. But then there's all these ones in colours other than orange that are also deaths from probably sepsis. So we need to get a little bit better at understanding the epidemiology, and then from there we can then really target some things that we want to improve from a data perspective. Obviously there's tons that we can do from a clinical and an innovation perspective, but in order for us to track progress, we need to understand the numbers. There's organisational considerations as well. So when you think about lots of things in which the NHS has changed its approach to how we deliver care, you can see that in many conditions we've moved from a model where we try and do everything everywhere all at once to trying to do things really well in a smaller number of places. So the delivery of vascular surgery, for example, is an example of that. We've moved from vascular surgery being delivered everywhere to a smaller number of vascular centres. Same with strokes. The ambulance will fly past the place that isn't a stroke centre and take the patient to a stroke centre because we know that they have optimised pathways that should improve outcomes. Now, you have to therefore ask yourself the question, is sepsis an example of where we should be adopting this approach? And the answer to that is no, it isn't. So this is a funnel plot that shows you mortality rates by hospital according to the Standardised Hospital Mortality Index. So it's adjusted for some of the things that we know make a difference to whether or not a patient is likely to survive, like age and long-term conditions. And this is the shimmy specific for infection. And what this shows you is that there is no clear volume outcome relationship between good and bad hospitals. So the reason that we narrow services to a smaller number of hospitals in some cases is because there is a volume outcome relationship. So the more that you do of a particular type of surgery, the better your patient outcomes, for example. But we don't see that in sepsis. And that's important because, of course, any patient can get an infection. And sometimes those infections happen in patients who are hospitalised for completely different reasons, like they've had a stroke or they've had an operation. So every hospital needs to have the capability of being able to diagnose, escalate and treat a patient with sepsis quickly, whether they come in through the front door or whether they come in electively and then get something else. Sepsis has a huge cost to human beings, but also to the service. And of course, we can't completely eliminate infection, but what we can do is try to limit the adverse consequences of infection, severe infection, and sepsis. So the modern service framework in sepsis has 4 key areas. We have to set, for all the MSFs, we have to set an ambitious outcome goal. We have to have a focus on what we're going to do in terms of themes and actions for the day-to-day service here and now and over the next 10 years. We have to have an approach to improvement and assurance, so how we're going to improve things, how we're going to get to our outcome goal. And then we have to have an approach towards research, innovation, and the sort of blue sky thinking and how we're going to get there. Now, the MSF is going to be published in the next couple of months, so I can't go into the fine detail of what we're going to do, but I'm going to give you some headlines, some overview of it. I'm going to tell you a little bit about how we designed it. So we got going in August, September last year. It's been a very rapid process. Any of you that have been involved in the development of guidelines, even at local level, know that to try and get something comprehensive done in 6 months is actually quite a tall order. This is something that has taken us 6 months, and it's involved multiple stakeholders from all over the country. It's going to denote how we do things for the next 10 years. So it's been quite a journey. We've involved stakeholders from all over the country, from hospitals up and down the country, from different stakeholder groups like Royal Colleges and so on, also from the NIHR and other research bodies. And what we've really tried to do is draw on the collective expertise that we have within the NHS to try and co-design this. Also, really importantly, with patients and public, with whom we've done a lot of sense checking as we've gone along. So we've used the PEER framework, which I'm sure everyone in the room is familiar with, the Prevention, Identification, Escalation and Response framework that was coined by the Patient Safety Team nationally to structure it. we have focused on what we can do in the here and now to optimise existing pathways, as well as looking at what we will be able to do in the future through, for example, advances of the type that Kira's just been talking about. And then we want to think a bit more blue sky about what the art of the possible is from the R&D perspective. So as I say, it's the peer framework that we're using. Important to recognise that this is not a secondary care thing alone. Now, if you go back to the definition of sepsis, and how many people in the room come from a primary care or a community care setting? Well, it's brilliant to see you here. But as you would expect, the majority of us are in secondary care. And sepsis, while of course it occurs in primary and community care, is predominantly treated in secondary care. Now, what we want to do through this framework is to prevent sepsis. And that means obviously preventing infection, but particularly preventing transmission of infection, preventing infection becoming severe infection, which we're identifying as hospitalisation with infection, and then preventing infection becoming sepsis. So the prevention aspect of it is really important. And therefore we go beyond, for example, in the research and innovation questions that we're posing, beyond what the James Lind Alliance has done, that brilliant piece of work to identify priorities for research in the future, but focusing on sepsis itself, whereas we want to focus on the prevention of sepsis as well. So the whole idea is that we move the pathway to the left. We shift everything. So we want to, I'm an intensivist by background, I want to put our specialty out of business. The other thing that's important here is the cradle to grave approach. So I'm an adult clinician, but of course sepsis does affect every age group, as I've already shown you. But also, really importantly, it affects us disproportionately based on things that are not within our control. So health inequalities in sepsis and infection are real, and we need to address them. So our goal is not just to reduce the overall headline statistic of deaths and morbidity from sepsis, but it is to improve it in all patient groups, by age groups, broadly speaking, but also by health inequalities groups, people with learning and physical disabilities, people of different genders and different socioeconomic statuses. So we want to do that too. So which outcomes and which patients? So the outcomes, so obviously death is the easy thing to record and to measure and to monitor, but we want to do more than that, because as we all know, as critical care particularly gets better, as detection of sepsis gets better, we save people, we rescue people from death, but they can be left with terrible disability, both psychological and physical. And some of these patients don't even need critical care. Some of these people have a post-sepsis syndrome without even really needing organ support, but they still have the horrors afterwards. And so we want to measure and improve all of these different outcomes. So not just death, but severe complications, which we're defining as admission to critical care for at least single organ support, and the long-term impact or harm associated with it, which loosely we're defining as, well, not loosely defining, we're defining as days alive and out of hospital at 365 days. Now, our patient reps say, well, that's not a very patient-friendly metric. And of course, they're right. And what we should be measuring is things like health-related quality of life, disability-free survival, those sorts of patient-centred, patient-reported outcomes. The problem is it's very, very tricky to do that at scale and without bias, because people don't respond to questionnaires and so on. So I'm not saying we'll never do it, but we've got to start somewhere. And so we'll start with a metric that we know that we can easily measure through hospital episode statistics. We want to improve both the absolute numbers and the rates. Now, that is important because we know that there's a general increase in the number of infections. And so even if we were to reduce mortality, morbidity rates, we might still see the same number of people dying or succumbing to serious complications. So we are trying to set ourselves ambitious goals, but we must be realistic about the fact that if wider infection is increasing due to things that are way, way out of scope for a sepsis modern service framework, then we have to acknowledge that and then see whether we need to redirect our focus in the future to different areas. And then I've already covered the all patients group aspect. So we want to make sure that we don't just improve overall outcomes. We do it for adults and children and neonates. We do it for people from different health inequalities groups. particularly for people who come from different socioeconomic positions, but also the statistics for outcomes for people with learning disabilities and autism, for example, with sepsis, are shocking, and we need to address that. So I've already said that we're using the peer framework, and we've added a couple of other things to the themes that we're using. So we want to take a person-centred approach. So that comes back to what I've just said about improving outcomes for everyone, no matter what their background. But it's also about using individualised approaches to treatment. So those of you in the room who are intensivists will feel the same as I do about that sort of deep sigh whenever you see a paper come out. There's a big randomised trial that we all had lots of excitement about, and yet we don't see necessarily an outcome improvement there. And at least some of that may be down to the fact that we're not individualising enough when we think about our interventions. That, for example, steroids might work better in this group but not that group, or some other immunotherapy might work better in this group, not that group. And so how do we define those groups? Do we do it on the basis of the etiology of their sepsis? Do we do it on the basis of some genomics or other omics? I don't know the answer to the question, but what we need to do is get more towards personalised approaches to treatment and then to how we innovate as well. We need to support ourselves, our people, our staff and our population to do better. So some of that is about education and training. Some of that is about how we support clinical staff, both in healthcare but also in social care. And some of that's about the general public. And that's a real challenge because public awareness campaigns like the stroke campaign a few years ago, I think, have a potential massive risk associated because most infections are not that serious. And so what we don't want to do is scaremonger, but we do want to appropriately inform the public. And then we've got the peer framework. So how do we prevent infection through, for example, strengthening our approach to vaccination? Again, that's a big health inequalities question. How do we identify sepsis quicker? I've been in clinical practice. I qualified in 1997. We have not moved on a great deal from blood cultures, CRP, and white cell counts in terms of rapid diagnostics. There are some advances, but not that many, so we need to do better. The escalation, so for example, we all know about Martha's Rule, we all know about the use of News 2 and other early warning systems, but are the approaches that we're taking right? Is it right that we escalate in the same way for a 35-year-old and a 95-year-old? Does that make sense? Or somebody with a long list of long-term conditions, or a marathon runner? Does that make sense? I don't know the answer, so we need to find it. And then what should that response be? Can we do it in a timely way? Do we have enough intensive care beds? Do we have enhanced care services that can provide the support for patients that need peripheral vasopressors, as in NICE guidance I know you heard about earlier, but then might get treated in a corridor outside A&E with their peripheral vasopressor going? So we need to improve the way that we deliver that care. And then finally, and I know something close to everyone's heart, is the rehab. So how do we look after patients beyond their acute illness? And then a big bit about innovation and research and development, looking at 6 slightly different themes, thinking about people, thinking about prevention, and then the prediction, the monitoring, the identification, and the diagnosis of sepsis as well. So the Sepsis Modern Service Framework is coming soon. I've given you a little taster of what's in it. What I would like to do is for you to leave this room feeling excited as people that are very interested in sepsis by virtue of the fact that you're here, that this is the first condition that has been highlighted for the publication of a modern service framework. We're racing the cardiovascular people to get it out there before them, we shall see. But it will be coming soon. I hope it will make a material difference to your working lives, and thank you very much for listening.